All right, Ingrid.
Okay, thank you guys for joining us today. Can everyone hear me? Thumbs up, thumbs down, okay, good. So thank you for joining us again. This is our second discussion around health equity. And so I want to give some kind of framing to this discussion today. Last time we talked about why do we find that this pandemic is having more of an impact on certain communities, focusing a lot on the African American community. And so this time we will move forward in that conversation and talk a lot again about the systems at play. So not how individuals are, making poor lifestyle choices and things of that nature, but what are the systems at play here in our country and other countries that make it so that certain groups are more susceptible to any type of social ill, to include a pandemic. Again, we want to think about this systems. We want to think about the big picture. How are we making this country work in a way that only works for some and not for others? And so just to give a disclaimer, I have a 2-year-old and a big dog in the background, so you might hear them. And I want to introduce our panelists, and then we will kind of dive into this. So first up, I have Joshunda Sanders. She was here with us last time, and she is a former speechwriter out of the Office of Minority Health for the Obama administration. I have Sarah Bounse with us today as well, who is with the Office of Health Equity with Vanderbilt Medical Center. And then I have Dr. Sanmi Areola, who is a Director of Health and Environment with the state of Kansas. And so I would like to invite you, we'll start with Joshunda. Please introduce yourself and why health equity is something that is close to your heart.
Hi, everyone. Thank you for that lovely introduction, Ingrid. I have been focused on health equity for most of my life, in part because I had a mother who had mental health issues growing up in the Bronx, which many of you may know, but some of you may not. It's the home to the poorest congressional district in the country. And so social determinants of health and other impacts of trauma and poverty on our health has always been of interest to me. So that's part of why I'm engaged in this work and this discussion.
Thank you. Zara, let's go to you. Tell us about your role at Vanderbilt Medical Center.
Yeah, so thanks for having me here today. My name is Sarah Bounse, and I work at the Office of Health Equity at Vanderbilt University Medical Center. It's a pretty new office. It's been around for about a year. And my role there, the focus of the office is 3 parts. So it's looking at community and population health and building partnerships with community members and community stakeholders. Then we have a research component as well. And then we have the education side. So my work primarily is focused on the education piece, where I'm working with students around health equity, understanding health equity. We have a certificate program for medical students, and we're hoping to expand that to other graduate programs. But really that's my focus area, as well as doing some cross-cutting work with our community work, as well as like internal research. So health equity matters to me because I got into health. My work around health really was, my interest in that was from a young age of wanting to help people and impact and improve their health, and recognizing and realizing as I got older that for some reason certain communities had poorer health than others and didn't really make sense to me. And so started delving deeper into that and really recognizing, yeah, it's a systemic and that it's lifelong work. And so that's really that's where my heart's been pulled into. So yeah, I'm glad to be here. Thank you.
Thank you so much. Next we have Dr. Areola. Please share your experiences as it pertains to health equity and your role as the Director of Health and Environment. Dr. Areola, you are muted at this time, so you can come off of mute.
See, that's it. Can you hear me now? Yes, okay, thanks Ingrid and Sarah, good to see you, and greetings to everyone on the call. Sanmi Areola. I'm currently in Johnson County, Kansas. I'm the Director of Health and Environment. Until about 5 weeks ago, I'd spent the previous 17 and a half years in Nashville, Tennessee, and the last few ones as Interim Director and Deputy Director. Health equity, I think it's central to everything that we do in public health. It's actually difficult to do public health without addressing health inequities. We know the factors that work for health. Without straight, I know we're going to get into COVID-19 responses, but there's a very linear correlation between poverty and health outcome. Basically, if you're poor, your health is poor. And I typically will give example of the few, what is called high five that I think the CD does, which is health impact in 5 years, that even the earned income credit of $2,000 makes a measurable impact in health. And so social determinants of health is all about health inequities. And if we would get away from cumulative numbers and actively look at numbers that matter and work on those things, we will truly improve our health. And so thanks for having me, Ingrid, and I'm happy to talk in a little bit more details about this.
Yes, and thank you to all the panelists. And so again, let's come back to framing. In our last discussion, I really talked about one of my favorite theorists, Bronfenbrenner, who talked about the different systems at play in any society. And one of the things, or one of the larger systems, is called the macro system, and this houses our beliefs and attitudes. And so I want to bring that back to center today, because the beliefs and attitudes that we have as a collective, for the most part, again, we tend to favor white people. We tend to favor men. We tend to favor people who are well off financially. And we definitely favor people who are able-bodied as opposed to people living with disabilities. And so this is a part of our larger ideology within our society. It's embedded. And that's why a lot of issues around health inequities are based on our individual bias. So that individual doctor who has to make a determination about who's going to get a test and who doesn't. I mean, that can be a source of inequity in that space. So people who need to get tested who aren't because they didn't travel, or because they don't live in the certain neighborhood where it's a hot spot. All these different decision-making issues are embedded in bias in our macro system. Another good example of how the macro system is at play is colorblindness. When we say that we're all in the same boat, which is something that's coming up a lot around discussion around this issue of COVID-19, that we're all in the same boat. We are not all in the same boat. We have a different array of privileges at this time. So some of us are able to work from home. Some of us are able to have our children schooled at home. And so we're not all in the same boat. And this definitely reminds me of kind of the color blindness attitude. What you'll find is as we get through this collective trauma, when we get on the other side, you'll find that certain communities have been ravaged. And those communities are going to align with the inequities that existed before this pandemic. And let's talk about that. What are these ideas, these large scale ideas that is really impacting our ability as a country to have better healthcare for our citizens? And obviously the first one is going to be racism, that we value white people, white citizens over others. And this is historic. This is endemic within our society. It has been at play since the beginning. Whereas before it was much more intentional, now it is institutional and systemic and unconscious. And so I asked if any of the panelists want to talk around the issues of implicit bias and racism within these institutions and how it's impacting health.
Areola here. I'll take the first stab at this. And I think you listed, you went through the historical historical steps there. I think one of the lines that I love is where we are is a consequence of the policy decisions that we made decades ago, and that for us to get better, we have to be intentional about the policies that we make. And policies are as good as the assumptions that underlie them. And if those assumptions are heavily weighted towards the majority population and people that are privileged, then our health numbers are not going to change. And also the beliefs are very important. They are different in the African American community. They are different in the Hispanic community. And those are the people that are at that takes the brunt of the worst end of the scale. It really doesn't matter. We're going to get into COVID, but look at all the underlying conditions, whether it's cardiovascular or pre-existing heart conditions. Those are the things that we know disproportionately affect the African American community. We also talk about this issue of addiction, and I know it's kind of died down, overdose and those things. A few years ago, when it was cocaine and crack, we knew what the policy was. So those systemic features continue to be there. They actually, I like to go a little bit upstream before I look at individual health conditions. We say that zip codes determine your health than genetic code. So go and look at the Black community, look at the white community, look at the people on the high socioeconomic scale and people on the low socioeconomic scale, and that's where you get the story. If you want me to walk, you want me to be more active. You want me to eat healthy. Well, so when I step out of my house, make sure that I'm not afraid of the police, make sure that I have sidewalks, make sure that it's not dangerous for me to step out. Otherwise, you're just preaching to me. If you want me to eat healthy, make sure that I have resources where I can go and buy them in my community. So the historical inequity are there, and until our budgeting and everything we do addresses those things, we're going to be at the same place. And lastly, I'll tell you, in this society, if I get into a very hard time, the perception is I'm being lazy, I didn't do the right things. Now, if you go to parts of Europe, Sweden and whatever, if you go into hard times, the question more is, what did we do as a society to fail you? How can we bring you up so that you can be in a better position? So until those politics and perceptions change, we're just going to be moving around, and those are the facts.
Yeah, I would echo that. I mean, really what Dr. Areola said. And I think with this, just like with lots of other health issues that we look at, the solution seems very simple, quote unquote, right? Wearing a mask and social distancing. But we know that the reality is that there are so many barriers and obstacles for all people to be able to practice those solutions to like preventing COVID-19, right? And that requires a deeper analysis of what's going on in our communities, right? So lack of paid family leave, lack of sick leave, lack of, we have our health insurance is tied to our employment. And if you lose your job, you lose access to that. These are deep systemic things that need to shift. And so when we look at individuals that aren't wearing masks or are just out and about, kind of have to delve deeper and ask ourselves why, and like what's going on here that is preventing people from using resources that may be available, but actually right now, a lot of these resources aren't available and people are having to make their own masks, right? And does everyone have the resources to do that or purchase them? So I think that kind of assumptions that often people get lumped onto them is something that we need to kind of manage during this time. It's like, why are people making certain choices right now?
What I would add is that I think that there is a hope that all of the temporary changes that have happened in the public health system will remain. Expanded access to telehealth, for example, or Medicaid expansion, for people who have opioid addictions, for example, a lessening of restrictions for ways to treat them and medications that they can use to treat them. But history teaches us a lot, which is that even when we go through collective trauma, that seems like we have opportunities to change things. That doesn't necessarily mean that the power structure or the things that we haven't discussed, like racism, like the way that white supremacy is sort of enshrined into the public health system or healthcare system writ large, and the deep economic gaps that there are between, say, doctors and physicians who are at the kind of the top of the scale, and like Sarah mentioned, employer-based healthcare, which one expert I spoke to described it like an umbrella melting in the rain when you have more than 22 million people out of work, right? It just melts, so so I would say that as much as we may hope as optimists that our system will be forever changed because of the sheer scale of what we're dealing with, there are still things that we just haven't really reckoned with as it relates to race and racism and the history of how it's connected to everything else that impacts marginalized people.
Yes, thank you guys. Thank you for your perspective. And I noticed a trend that was clear between all three of your responses, which is how much racism is embedded within our society, and even further, how racism is impacting all aspects of life. So when we think about this specific pandemic, we have the epigenetic changes that are there when it comes to people who experienced historical trauma. So genocide of Native Americans, chattel slavery for African Americans has changed DNA that makes us more susceptible to chronic disease. And this is evident in that those two groups have the lowest life expectancy in this country. And then we have sorry, I knew that was gonna happen. We have the economic issues. And so we have people who are kind of funneled into certain jobs, funneled into shift work, funneled into hourly pay, funneled into work that they can only get because they do not have citizenship or documentation. And they are more susceptible to issues around this pandemic because they have to work. They're essential. They have to get out. They can't work from home. They have to work in a way where they are interacting with people. They are delivering groceries. They're delivering, they're driving your trucks. They're out in fields. They're making sure that you're getting fruits and vegetables during this time, and meat in our manufacturing sector. And all of these different sectors are more likely to have people who are poor, more likely to have people who are not stable in their health insurance, more likely to have people who are in situations where they can't social distance, and more likely to have people who are brown and Black. And so we have to acknowledge that that is a system. There is a reason why certain positions, certain industries have an overrepresentation of certain groups, and that's because they were structured in that way, and it is very much intentional in its beginnings. And hopefully we can use this time as kind of a reset to move forward with more equitable recovery. And so let me ask, my panelists, what would equitable recovery look like?
So the COVID-19 SARS-CoV-2 is the kind of we haven't seen this kind of virus in a long time, and everything you said, given my experiences here in Johnson County, has been completely accurate. Even in the testing, you could have inequities in there, because if you strictly base your testing on the high risk hospitalized group, those are skewed towards people that are older. And for somebody without health insurance or whose immigration status is in question, they will not go and do that. And here, the percentage of minorities is really about, it's small compared to Nashville. But the essential workers, like you rightly noted, are the minorities. So there's got to be a little bit of intentionality there. And so we intentionally focused on the essential workers and intentionally focused testing in a population of low socioeconomic statuses and minority communities. And as we move forward, we have to identify those subpopulations and target interventions towards them. We cannot permanently shelter in place. I think there are some things we do, social distancing and those hygienic processes that needs to continue no matter what. But just even the gating criteria that the White House put together that we're looking at, if you're looking at cumulative numbers, there are places that could potentially meet that. But when you dive deeper into those numbers, there are some populations that are not quite there. For us, 4% of our population are African American. 12% of our positive test is in African American. So the disparities and the number, we have to use numbers to guide our decisions. And I think moving forward, recovering from this, and it's good to hear politicians talking about that, but we've seen that before. It's really putting your money where your mouth is. Moving forward, how are we going to remove these inequities? How do we ensure that we just don't use cumulative numbers, but look at subpopulation, whether in testing, contact tracing, or whatever we're doing moving forward, to understand what the impacts are. And by the way, I think we have to look at those pre-existing conditions that we're all putting out and look at those even as subpopulations to target interventions.
I mean, I think, again, echoing everything that Dr. Areola said, and I think there's a lot of good comments right now talking about, really, I mean, I think, how do we build, what would equitable recovery look like? I mean, I think that means just dismantling all of our systems. I don't know if that's possible, but I think that, you know, the root of these inequities that we're seeing with COVID-19 are from inequities that have existed and continue to be perpetuated in all of our systems. And so I think, you know, really, and I think that people have put this in the comments around listening to impacted communities is so critical. What do people on the ground who are marginalized like actually need, and what can people in power, institutions provide to help and support these communities, I think is so important. And I think that there is some conversation around that happening at the national level, even though it's not, you know, we know that that's challenging. And then I will say another thing that we talked, Ingrid, you brought up like stories and narrative that is told, and like the belief systems that we all have kind of been indoctrinated to being in the United States. How do we shift those narratives? You know, when we're thinking about specifically, I think about essential workers. Who is deemed essential right now are people that are in grocery stores, are picking and getting fruit, are farm workers, are, you know, people on the ground. And previously the framework, that the narrative around those folks was that they're unskilled laborers, right? Or they're taking our jobs. And what we see is that no, they're actually very essential, right? And nobody actually wants to take those jobs right now, right? Because they're on the ground. So how do we use and kind of firm up that narrative to say like these people are essential, and so we need to shift, right? We need to make changes to ensure that all people are safe. I think that's so important. So, yeah.
I think everyone sort of covered it, but you know what I would also say is that you know, I heard someone say recently that you know, change. One thing that we can count on for equitable recovery has to do with the fact that change has, when there's been a demand for change, the systems have always changed, right? So if we decide, I think collectively and as part of these different populations, that we want Medicare for all or universal health care or these kinds of things as a society, that we can actually push for that change. I think that there have been there have been some flaws in the COVID-19 response that obviously everyone can see. But I think, you know, like Dr. Areola said, you know, people really have to put their money where their mouth is, right? Like there was a comment here about like there not being a Whole Foods in many communities. I live in the South Bronx. I have to walk to Harlem to get fresh fruit and vegetables and wait on a line that until very recently was not a socially distanced line. So, you know, I think in some ways more in common with some of the essential workers than your average person who can stay at home, right? So there are these nuances that we have to consider when we talk about people's narratives and what is possible in terms of recovery.
Yeah, and the chat is looking awesome, by the way. You guys are definitely saying good things, and I just want to draw on a lot of what I'm seeing in the chat around systems change and the role of grassroots organizations. And I know, you know, ACES Connection is all about, you know, grassroots movements and supporting them so that they can do the real work. Because so many times, like Dr. Areola said, when it comes to putting your money where your mouth is, this is where we get hung up. And so the research around racism and the social determinants of health and the disparities that exist, they've been around for quite some time. You know, a lot of the work that I do, I'm also a professor of psychology, and I work with African American psychology, and I have to draw in history when I talk with them about racism, Black identity, and things of this nature. And so much throughout history, you can see how we've had issues in the past. When we think about the New Deal and recovery from the Great Depression, and you know, all of these different ways that America has had to rebuild, and every time they've had to rebuild, they make sure that those inequities are still in place. Often in very intentional ways. And so when they have money to rebuild America, will it go to communities of color? Over and over again, we see that it won't. And so when we think about the history of this country and around the world, because racism and inequities are impacting all of our societies, when we think about what that's really going to look like, it's going to be on the backs of grassroots movements. Because again, and I hate to be political or in any way inflammatory, when it comes to capitalism and you know, politics in general, decision makers have shown us over and over again that when it comes down to it, when they have their pie and they're ready to split it up, when it comes to recovery and resources during this pandemic, a good example would be fast acting testing. When we have a fast acting test for COVID-19, will wealthy white communities get it? Will they make sure that that fast acting test is available for low income communities or mostly Black and brown communities? And you will find that those fast acting tests will go to those richer, mostly white neighborhoods. And so these decisions are being made, and every time there's an opportunity to make a different decision, that's not what happens. So I really just want to pose to the panelists and to anyone who wants to comment, how will we conduct ourselves during and after this pandemic to make sure that as resources come available, that they go to the right people, the right communities, so that we can all get to a point where we are all healthy. So.
I don't know if you are wanting to call, there's so many good comments by so many people that I don't know who to call on. Is there a particular comment that is really speaking to you that you want to, maybe Angelina or Angelina? Let me find, okay.
And also Dana.
Okay, cool. So we'll do Angelina, then Dana. Let me unmute you. Okay, you're unmuted. Go for it.
I made two comments. I made one about farm workers as essential workers, and then I made one about code switching. Which did you want to talk about?
All the above.
Okay. All right, cool. So I guess what I'll say about farm workers is I come from a line of farm workers. My grandma's one of 14, and they were all farm workers growing up. And so I've seen them struggle, and I feel like I'm working for them every day, you know, now that I've been privileged enough to go to college and graduate high school and do all of these things that people in my family couldn't do. So it's interesting now to watch it from this side, and being a person of some privilege to be able to see how, like, as you said, these people who were considered unskilled, unvalued, are now considered essential. And I can guess that many of these people, all the people that applied for unemployment, I wonder how many of those people are willing to go out there to the fields and also contribute to this. I imagine to be close to zero. So I would really hope that we can start to change that view after that. And as far as code switching goes, so I'm in Oakland, California, one of the most diverse cities in California, and I serve mostly African American and Latinos here. Many are undocumented, many are foster children, homeless, and everyone's a victim of gun violence. No one walks through my door unless they've been affected by violence in their community. And many are on probation. Many of my clients are incarcerated right now, even in juvenile hall, and they're not releasing people from there. They're not releasing people from juvenile hall, which is putting them at risk as well, because as we all know, it's impossible to be 6 feet apart in prison. So many times when I go to court, if I would like to teach my kids and parents to advocate for themselves and be assertive, but as we all know, sometimes that's just not effective in the courtroom with police officers and certain entities. So when I'm there and I come in with my light skin and my light hair, and as you can hear, I don't have an accent, people listen. When we're in the courtroom, the judge addresses me. They don't address their African-American caseworker. They look at me. And it isn't until, you know, they see my last name or hear me talking to a parent in Spanish that they realize, oh, are you not, did you go to college? I'm like, I wouldn't be here if I didn't. I'm a therapist, you know? So it's been a big part of my job, and it's something that I've learned, and it's, I've learned to use it as more of a superpower now, and I really like being able to advocate for people and have the opportunity to be able to do that, because no one did that for me growing up. So it's really nice to be there and do that. So anybody who can learn how to do that and use your powers for good, I strongly encourage it. Be brave.
Thank you, Angelina. You said a couple of things that really hit home for me, and it's something that I've talked with my students about before as well. And so when we talk about essential workers, to me, especially knowing the history of slavery, I mean, this is something that has been recycled in our society so many times. There is this need for unskilled, low-paid labor that the rest of the society is able to thrive on their backs. And this happens over and over again. And what it really shows is, just like the slaves in the past, today, essential workers, they've always been essential. Whole industries, our whole economy is on their backs, just like it was on the backs of slaves. And so you really have to understand that a big part of this issue, what's driving this inequity, is the ability for certain groups to live comfortably, which is, I think, you know, that's a part of the American dream, right? For us to be able to pursue our freedom and liberty. But if that's going to be the case, we need to get to the point where we are able to invest in those groups whose backs we are, you know, living on. And we need to be able to pay them well. We need to be able to honor them in their positions. And so I think that really hit home with me. And then, of course, code switching is, and allyship. So, you know, we have, you know, white allies are they're the group that are going to change what we have been struggling with. All of us, we are talking about the same things, but at the end of the day, this is an issue that white people are going to have to fix, because it's an issue that white people have created. And so when it comes down to who's going to be able to make these changes, it sounds good to say that we're all in this together, but a lot of the heavy lifting is going to have to be around white allies, those who are in positions, or white passing, because like Angelina said, if you can be white passing as well and have the power of passing as white. And so those individuals, and as an entity, are going to be the group that addresses this and actually makes a change. And so it really is about people accepting privilege, all that comes with it, whether it be skin color or socioeconomic, and then saying we need to change the narrative around oppression and around race so that we can really have the changes that we want. If not, then we will continue to suffer as a country, as a whole. We will continue to suffer with issues of racism in lots of different ways.
Ingrid, can I make a couple of comments? Yes. Okay. Yeah, and I completely agree with the comments. Excellent comments. I do want to temper our expectations a little bit around essential workers until I see improvement in how we treat them in the pay beyond this period. I remain very skeptical. I think essential because they're very important in keeping us going at this time. I haven't heard that they are having pay raises. I haven't heard of improved conditions. So I think we, just because they are tagged as essential, I don't think that changes the perception around them or how they are treated. I want to, again, just using my experiences here, we were very intentional in conducting extensive testing within that group under the premise that they are really the biggest indicator of what's going on, because we asked the rest of us to stay at home, but they're out there. So that's intentional. We were told to do some random sampling in our homeless population. We decided to test everyone. Those are intentional decisions that you have to push for. And one of the first things that we did, and I know it's across the country, is to work with the sheriff and drastically reduce our jail population and ask people to go home. So to me, you asked how we can help moving forward and ensure that the resources that are being distributed goes into the communities where they are most needed. I think we need to spend time understanding. There's so many people, everybody think it's just one bucket of money coming through. No, there are so many of them, and we have to spend time understanding those. Even though they are out there going to be spent are not completely clear, but once they get to the local government, there's a lot of people that are eyeing those money and looking to do different things with them. That's where I think advocacy comes in. And just with my years in government, I know you have to use existing relationships, people that you know that are in position to make decisions. One of my very last presentation to the mayor in Nashville and his team is really making a case to include equity in their decisions around budget. Sarah can testify to some of the earlier works, but really explaining to them how, with the mayor coming out saying, Nashville is so rich. We've grown our economy by about 35 billion in 3 years. That's double the worth of Chattanooga, but it's inequitable. So I'm asking then, how do you translate your words into action? That's some very basic things. Build sidewalks in this community, infuse more resources into this community. And I think that's what you've got to do to use our local politicians. And I found out they understand this, but they don't deal with this like we do every day, and they cannot articulate those factors. So how you work with them to help them articulate that, I think it's very important. But advocacy, we are working on our recovery plan, how to start rolling things back, and the people in certain business sectors that are effecting changes, and whether they open first, they open last, are people that are making noise the most. They are bombarding everybody with emails and phone calls, and it's causing the decision makers to pause and actually make changes. So you cannot underestimate the impact of advocacy.
Yeah, I think I just want to uplift what Dr. Areola just said around advocacy. I mean, I think at the local level, because I'm seeing it, I'm in Knoxville, Tennessee right now, staying with family, and I see it happening at the grassroots level here around people that are frontline, like hospitality folks, or people that are servers, or all that kind of like those kind of positions, kind of creating coalitions together to say, hey, we don't have enough protections right now to open up. Like, we don't have enough testing. Let's talk to the mayor, let's talk to the health department here, and really advocate for widespread testing. And if that's not possible, let's hold off, you know, an opening. So I think advocacy on that level, and also advocacy like at the state and federal level, we're seeing opportunities right now. I mean, I think we're in such a space of so much change happening so quickly, with laws being passed, the CARES Act being passed so quickly, and another iteration going to be passed soon as well, that there's so much opportunity for change, and things that have already been passed that were problematic. So the stimulus package for getting $1,200, that one-time check, if you're an undocumented individual, you can't get that check. But if you are also married to an undocumented person, you can't get that check, and your children can't get that check. That is really troubling and problematic, right? And so how do we advocate against things like that? And I think there's opportunity right now to do that. So yeah.
I would love to hear Clifford's comment, and let me unmute you.
Right, that'll work. Hi, yeah, I'm Clifford Barnett, and I'm in Wilmington, North Carolina. And one of the questions I had was, you know, we talk about getting people who are privileged to help out those who are not privileged. But one of the challenges I have oftentimes is that many persons in privilege don't see the need. So how can we really meet that need if they don't see it? How can we get them to see it?
That is an excellent question. And I think that when it comes to, especially during this time, when we're kind of more connected than we've ever been in our history, it's going to be about messaging. And there's a lot of science that goes into messaging. You know, framing discussions in the right way that lead to action is going to be important. But it's also going to be about using the tools that we have. So social media, and even, you know, this type of platform, social networks, are really going to be our biggest tool, especially now when we're social distancing. But everyone's kind of plugged in, into social media, and we really need to rely on entities like ACES Connection to get messaging out to the public that is saying, you know, this is a real issue, this is how it impacts you. When one of the ways that I talk about it, and it is a virus, oddly enough, was HIV/AIDS. And this is how I get my students to understand how we're all connected. So as we, you know, when the HIV/AIDS epidemic was really ravaging our country, in its beginning stages, it was totally ignored politically. People had the ability to put effort, research, and money behind addressing this mysterious illness, but they did not feel compelled to, because it was impacting gay community. And so, and their understanding at the time was that if you were gay, you were not in need of compassion, empathy. And this is the same thing as racism. It's the same thing as sexism. I mean, this plays out in lots of different ways, but my students are mostly Black. And so for them to step outside themselves, I have to think about different ways. And so as we let this virus impact one community with no intervention, then that then begin to be an issue for the entire country. And so as we allow racism and other types of discrimination to fester, then when we get hit with a pandemic and our systems begin to break down, those groups that you did not give resources to are not there to support you in your social economic status that you would know, you know, you take for granted that you're going to be able to get food. You take for granted that you'll have utilities. But because you have neglected certain people in your group, you've allowed oppression to become widespread in some areas, they are susceptible, and when we have hard times, they're going to be most impacted, which then disrupts the entire connectedness that we have in this country. And this, again, is something that has played out over time. We really need to get a clear message around how what happens over here impacts you, but then we also need to use social media as a way to make sure that we are all talking about the same things and we're all connected around these issues. The other panelists, do you have anything to add around that?
I think you covered it, Ingrid. I mean, there's so much, there's a lot to do there, but I think messaging is so important.
Yeah, I just add that, like, I think, you know, one of the things that's been most revealing to me, and I think to a lot of other people, is just the extent to which our health is so interdependent across groups. So, you know, I think that has been raised, but also understanding that, like, we can't necessarily offer anyone like a safe space, right? We can only offer each other like sort of this, it doesn't even feel courageous. It feels like there's so much fear, but I talk to my students often in writing classes about cultivating courageous space. And what that means in this context has to do with not being afraid to say the word white, right? Like, we're still in a world where there are some people who just don't even like to hear you talk about white people as like that being an issue as it relates to race. And so in terms of talking about messaging, you know, those of us who are white or white passing or have allies or have power in the old hierarchy, in the old world that we were living in before, as we transition into this new one, you know, making sure to kind of divest yourself of privilege in a way that allows you to really hear people talking, right? Because it's one thing to have advocates, but it's another thing, or have advocacy, but it's another thing to not have people who are receptive to even hearing the language of change, right? And hearing words that conflict you, or that make you feel convicted for being privileged, which I think is maybe the next phase of where we're headed, right? Which is that people will then begin to, yes, they can hear the messages, and the messages are strong and they're true and they're based in grassroots truths and realities, but we actually need people to be able to hear them as well as see them.
So I think what we may do, Ingrid, is maybe we want to take one more comment then from a participant, then do some closing remarks, and then wrap up. We probably will go about 5 minutes over today. But I'm thinking we want to do this again, since we're just full to capacity. I'd love to continue this conversation, Ingrid, if you want to do another one of these.
Yeah, I'm open as long as there's demand. We'll do it again. And there's definitely more aspects to talk about. I think we do want to talk more about equitable recovery. I think that's going to be the next step. And then we also want to dive more into institutionalized and systemic racism when it comes to the epigenetic piece, and that is really at the root of these underlying chronic disease issues that we're having in communities of color.
Absolutely. Let's see. It's so tough for me to pick. The discussion is amazing. And I just want to say thank you to everyone who's adding. This is really enriching the conversation that we're having. Let's see. Does anyone see it? I can't shoot. I don't even know.
So let's do this. I see all of the chat. We will send me the chat so I can have this to think about for the future sessions. And I think it would be good for us to close on ACEs. And so when we think about, we're here, this platform is through ACEs Connection, which is about adverse childhood experiences, which is essentially stress and trauma. And sometimes when we think about ACEs, we think just about children, because the survey was completed about childhood 0 to 18, but the survey was done with adults. And so I really want to use this few minutes that we have left to really translate what is happening in our society. Race, the issue of race, racism, and oppression, and also otherness that people experience in our society is a source of stress. Low level, ongoing, all the time stress that is in the now can lead to chronic conditions like heart disease and other stress-related chronic illnesses that would make someone more susceptible to COVID-19. The vast majority, 90% of people who are hospitalized due to this virus have at least one comorbidity, with the highest being all heart-related issues to include hypertension and diabetes. And so when we think about how all of these underlying conditions are really being driven by stress and trauma, and also historical trauma. So Native American and African American experiencing historical trauma, which has caused epigenetic changes, again, making them more susceptible to chronic diseases. And then when we think about Hispanic and Asian communities experiencing low-level discrimination that is also impacting their health outcomes. And I just want to really drive home that at the root of all of this is adverse childhood experiences. Experiencing racism is an ACE. And we really want to think about how we can take on diversity, equity, inclusion, and connect it with the ACEs movement so that we are equitable in our recovery, not just from COVID-19, but all aspects of prevention and recovery and healing in our country. And so I'll close with that.
Want to hear from each panelist to go ahead and wrap up.
So what I'll just add to that, I mean, I think that Ingrid really covered it, but what I would just add to that is that I think that until this moment, there really hasn't been a lot of recognition of our collective traumas. And so I think that this is a moment for us to all look at what we identify as traumas that still remain, and how we can sort of start to heal them, but also think about how we can support each other, because there are a lot of people who are experiencing this kind of trauma for the first time, or any kind of trauma for the first time, and kind of what the collective impacts of that will be.
Yeah, and I think, I mean, again, echoing what everybody's already said, but I think this is an interesting time in that it's illuminating, I think, for a lot of people to see the inequities that are manifest, that have always existed and that are being exacerbated right now. And the root is trauma, historical and current trauma. And I think we have an opportunity, though, right now to really make profound change in our communities and in our society, and to understand that trauma right now, we can do something about it, and that it doesn't have to be like such a profound ripple effect moving forward. And that can only happen, though, if we make real change. So really appreciate being on this call. Thank you.
Yes, thank you to everyone for coming, and we will have more discussions around health equity.
So Ingrid, I'd actually love to announce to everyone when we might do this again. I guess I'm just gonna throw a date out there. Would you be available to do this in 2 weeks, same day, Tuesday in 2 weeks?
Yeah, Tuesday sounds good. Tuesdays and Thursdays are working pretty well without me looking at my calendar right now. But
okay, I just love to kind of give people something to mentally
yes.
keep in your mind. And I have my calendar up in front of me, and we are keeping these conversations going. You all did one a few weeks ago. It was so popular and so inspiring that. And then obviously this is the second time we've sort of sold out and reached capacity on these calls. So it's something that's so needed. And we are so, so grateful for all of you being here and co-creating this ACES Connection community with us. I invite you all to continue this conversation on our website by joining as a member by just going to acesconnection.com and clicking join. Once you're signed in, you can post any content related to ACES Science that you want just by clicking the post button, and we invite you to do that. I've been reading the comments. You all are geniuses and have the most amazing ideas. Please come share that with us. Like we want your writing, like we want it. So please do post. Ingrid, the name of the community that you just started, I can never remember exactly the name of it. What's it called?
Yeah, on ACES Connection, I have a community called ACES and African Americans, and that community is really dedicated to stress and trauma within the African American community. And we are inviting everyone to post and to send resources, and then of course I will be posting from there. And the video from our first session is in that group as well, so you can check out the video from the first session. If you go when you go onto the site, there's a dashboard at the top, and right next to home is communities, and it's going to be very at the top because it's an A. So ACES and African Americans, and then you can go in and you can check out the video from our first session, which was really good.
It was amazing. So acesconnection.com, click on communities. You can join different interest-based or geographic communities. If you do not have a community but you want one and you live in the Northeast or the Mid-Atlantic, you can email me. If you live in the Midwest or Tennessee, you can email Ingrid. If you don't know who to email, you can just go, you'll probably email Dana, who's also on the call, and she'll point you in the right direction. You can find her contact info on our homepage. She kind of fields a lot of the random emails that we might get. So thank you all so much. This video will be posted on our YouTube channel on our website by tonight, so you can share it with people who you think really missed out. And we will see you again for the same discussion, I'm hoping in 2 weeks, if that works out for everyone's schedules. And then we also have education discussion for the same Better Normal series happening on Thursday with Laura, and nothing on Friday yet, so stay posted. But next week we have amazing conversations that we hopefully will have next week's schedule up by the end of this week. So we're getting more organized. It is happening. So thank you all so
Thank
much.
you.
And have a great rest of your Tuesday.
Thank you for coming.
Thank you.